Hi, everyone, and thank you so much for joining, and welcome to the Psychiatric Advanced Directives to Promote Community Living webinar in honor of the 25th anniversary of the Supreme Court's Olmstead decision. Please let us know who you are in the chat, and you can also include your organization, how you identify, whether you're a family member or an individual with a mental health condition if you like, and also where you're joining from. We're going to get started right away because we actually have a lot planned for you for today's agenda. First, I'd like to introduce myself. My name is Julie Erickson, and I'm a public health advisor in SAMHSA's Office of Recovery. I'm a white woman with blonde hair with an orange and white floral shirt on today, and also a person with lived experience with a mental health condition and also as a family member. I'm so excited to hear from our excellent presenters and panelists today. But before we get to that, we just have a few housekeeping items. Next slide, please. Audio is available through your computer by connecting to your phone under audio settings. Please use the chat to introduce yourself again. I see a lot of folks introducing themselves. Thank you so much. If you're comfortable, you can share how you identify as a family member or a person with lived experience, and also where you're from. Closed captions are available by clicking on the CC icon and selecting Show Captions. And if you have questions for our presenters, please drop those in the Q&A box. That's different from the chat. We really don't want to miss your questions, and the Q&A box is really the best place to make sure they don't get lost. And next slide. Just a quick reminder that the views expressed in the presentation today do not necessarily reflect the official views of the federal government or of SAMHSA, and we will be recording this event and making it available for sharing with others. And just a reminder that this recording cannot be distributed for a fee without SAMHSA's authorization. Next slide. Brief overview of today's agenda. We will actually start with a poll to see how folks feel and what they know about psychiatric advanced directives. And if you would just take a moment to answer this, the question is, are you aware of psychiatric advanced directives, or PADs as they're often called, and how to create one? So I'll leave this up for just a few seconds so that everyone has a chance to respond. So we'll have a sense of the level of knowledge in the room today. And are we able to, wonderful, thank you, Lee. Okay, great. So we actually have quite a spread, and that's great. We'll be covering some of the background information on PADs and also some new and innovative ideas that are being used in the space to advance PAD adoption. So I think there's going to be something here for everyone. So thank you so much for responding to that. Now we'll move pretty soon here to opening remarks and then some background information on psychiatric advanced directives, or PADs, as we'll probably be referring to them, and how peers can help advance PAD adoption. And then we'll move to our panel discussion and end with some Q&A. So you can skip the next slide, Lee. And with that, I'd like to turn it over to the Deputy Director of SAMHSA's Office of Recovery, Michael Askew, for some opening remarks. Michael, thank you so much for joining us today.
Well, thank you very much, Julie, and welcome everyone. I am Michael Askew. I'm the Deputy Director for the Office of Recovery and a person with living experience from substance use disorder. I am a Black American male with a bald head. I'm brown colored skin. I wear a full beard. I'm wearing glasses right now and a light button-up dress shirt. And I'm so honored to be with you all today for our Psychiatric Advanced Directives to Promote Community Living webinar. The Office of Recovery is grateful to all our guests for investing your time with us as well. Special thank you to Julie Erickson, Public Health Advisor for the office. Today, I'd like to just share with you a couple of slides. One is regarding SAMHSA's National Recovery Agenda. The aim and purpose is to advance recovery across the nation. And so we look to forge partnerships to support all people, families, and communities impacted by mental health and or substance use conditions to 1, pursue recovery, 2, be resilient, and 3, achieve wellness. Next slide. Here we have our SAMHSA's National Recovery Agenda goals: inclusion, equity, peer services, social determinants, and wellness. Inclusion, nothing about us without us. And this is really where we want to foster the meaningful involvement of a wide array of people with lived experience to improve behavioral health practice and policy, and to foster the social inclusions of people with behavioral health conditions. 2, equity, recovery for all, to increase opportunities for recovery for underserved and under-resourced populations and communities, including people of color, youth, older adults, LGBTQI+, rural, veterans, and people with disabilities. 3, peer services, peers helping peers. And this is to expand peer-provided services within each and every community. 4, social determinants of recovery, the whole healthcare approach. And that's to address key social determinants that support recovery, including access to housing, education, social supports, and employment. And 5, individual, family, and community wellness, to expand holistic self-care strategies to improve health and behavioral health outcomes, including the reduction of early mortality and impact of comorbid chronic health conditions, and to integrate recovery-oriented practices and system reforms into the full continuum of health and behavioral health care, including prevention, harm reduction, treatment, crisis care, and recovery support. I'd like to share a brief overview of the Office of Recovery. And so back in 2022, there was a convening such as the Recovery Now at SAMHSA, where we were informed and supported by the stakeholders and peers in the development and objectives of the Office of Recovery. The Office of Recovery and SAMHSA regularly collaborates with and incorporates the voices of people with lived experience just to do those things. Most staff within the Office of Recovery identify as being in recovery from substance use and or mental health conditions, or identify as a family member of a loved one who has experienced similar challenges. We're developing policies, guidance, and best practices such as SAMHSA's National Model Standards on Peer Support Certification. We're conducting technical expert panels, listening sessions, and dialogues as well. We utilize lived experience providers to conduct trainings and facilitate technical assistance, and we just love to be able to do that. Next slide. For today's webinar, we are honoring the 25th anniversary of the Olmstead decision, in which the court ruled that states are required to provide community-based services that enable individuals with disabilities, including those with mental illness, to live in the most integrated setting appropriate to them. As you see in the quotes on this slide, both the Olmstead decision and the Psychiatric and Advanced Directives emphasizes autonomy and self-determination for individuals with mental health conditions. As we continue to raise awareness about the rights established through Olmstead, we also want to build awareness about the tools we have to empower ourselves and our loved ones to receive the crisis support that we deserve in the settings we deserve, and the tool that is focus of today's conversation, and that is Psychiatric Advanced Directive.
Thank you so much, Michael. And now I'd like to introduce Harvey Rosenthal, our first presenter and also our moderator for today's panel. Harvey serves as CEO of the Alliance for Rights and Recovery, a peer provider partnership that has been a leading state and national change agent for over 3 decades. Under his leadership, the Alliance's advocacy has helped to transform state and national mental health systems, increase access to rehabilitation, employment, and peer-delivered services, and promote criminal justice-related reforms. Harvey has helped to create several nationally acclaimed and replicated peer support models, including Peer Bridger, Peer Navigator, and INSET, alternatives to coercion models, as well as employment and recovery-focused transformational training and technical assistance. In all, Harvey has dedicated the last 48 years to the promotion of public mental health policies and practices that advance the recovery, rehabilitation, rights, and full community immersion of people with mental and trauma-related challenges, as well as psychiatric disabilities and diagnoses. His interest in his work is very personal, dating back to a psychiatric hospitalization at age 19. Harvey, thank you so much for your work and for being here with us. I'll turn it over to you.
Thank you, Julian. Hi, everybody. I want to start out by thanking SAMHSA and Spark, my Spark team, because, excuse me, this topic is so near and dear and so important, and it's critically timely. And more people are talking about psychiatric directives as a powerful rights protection mechanism, and at the same time, a crisis response guide for members of our community. It's extremely important to me and any of us, really, that fight for rights and want to make sure that self-determination, even in a crisis, is available. So an advance directive is a written document that expresses your wishes in advance about what types of treatments, services, and other assistance, well beyond treatment, you want during a personal mental health crisis. A directive provides a clear statement of your medical treatment preferences and other wishes or instructions. You can also use it to grant legal decision-making authority to another person to be your advocate and agent until the crisis is over. And there's some research really to support the efficacy of psychiatric advance directives. There are research to show that people who complete a PAD experience significant improvement in working with providers and others because, their opinions and their needs are expressed already. There are fewer coercive crisis interventions. There's better understanding about preferred and prescribed medications. And there's the increased perception that personal needs for mental health services are being met. Other studies have found that clinicians and family members largely endorse it, and also that outpatients in public mental health clinics also find them to be very useful. Next slide, please. So I just want to read this one to you because, you'll see the slides later. We don't have a lot of time. But here's a person talking about why a PAD is important. The reason I work so hard to get my personal PAD in place was because I never know when the day may come when I will not be able to make decisions regarding my own psychiatric health care. During the darkest moments, the PAD speaks for me by allowing me to be an active part of my treatment when I am not able to. It is a gathering of my wisdom put to its best use to share with my chosen supporters those decisions I've made regarding treatment, providers, and visitors during a crisis. Next slide, please. So this is an example of an advance directive. We've been working in New York, Lusakini and I, on revising the tool so it's much more user-friendly. And we've been working with disability rights lawyers and New York City psychiatrists, a whole range of people, and the field, our people. So here's an example of it. I hereby appoint the person as my healthcare agent. That healthcare agent must be notified immediately if I'm determined to lack capacity to make my own healthcare decisions. If the person's unavailable, there needs to be an alternative healthcare agent available. And when making decisions, the agent will make best efforts to follow my instructions in this document. And if my wishes are not known, they will make decisions that they believe are in my best interest. Next slide, please. It also says, please notify the following people if I'm hospital, and please don't tell people if I've been hospitalized. So there's a lot of, they're able to reach out to people you want to be involved and also to exclude people that you don't. Indicate that providers, that you want to be involved in this and who have information to help with your care. You're in the emergency room. A lot of this really has to do with you're in a crisis. A doctor in an emergency room or others have declared you incompetent or, to lack the ability to make decisions. You need to be able to say what helps you and hurts you during that period. So the following may trigger or escalate a crisis: loud environments, being touched, apparent gender of providers. I may show the following signs before reaching a crisis: extreme confusion, intense mood swings, inability to sleep. But they'll also say, here's what's going to help me calm down: reading, listening to music, deep breathing exercise. Very important sort of guidance. Next slide, please. Says also, here's it's really important for, as we know, that peer services are very comforting and soothing and supportive. And here's, you can say in your advance directive, I'd prefer to go to a peer staff crisis residence, a peer crisis respite center, or a peer crisis stabilization center, rather to an emergency room or hospital if one is available. You're able to indicate, and specifically, these are the facilities and providers I want to work with and I want to go, and the ones I don't. I was a proxy for a woman who felt she was abused in the state hospital and didn't ever want to go there, but she didn't mind going to a local hospital that wasn't that far away. Very important information. Next slide. Now, in this form, when we say the word treatment, it's important to know it's beyond medications and therapies and counseling and other services. It includes all the things that you would say are really of help or a hindrance. You can say here in mental health treatments that should be considered if I'm in a mental health crisis because they've worked well for me in the past, XYZ. Now, I want to just say that too often people's medications are changed, and very often it's in the face of the medications historically have worked. So it's important for them to say, I tried this medicine, it did not work, and this medicine is the one that works. Doctors need to know that. Here's mental health treatments I will accept only under certain circumstances, and here are ones I will never accept under any circumstances. And I'm counting on my proxy, to make that clear. Next slide, please. Then here's one that says the document shall remain in effect indefinitely unless I revoke or change it, and it indicates the time that it might expire. And here's where you make sure that you have a witness who signs it as well. Next slide. So these are the challenges to the use of pads. Pads have been around for years, but here's the deal. Most people don't know about them, where they are, how to access them, who can help you fill them out. So this is a wonderful tool we're going to talk about, but it doesn't matter if we're not able to really do the things that are necessary. People need to be educated about them. They need to be helped to fill them out, and those helpers, which are often peers, need to be reimbursed so they're available. And the pad needs to be accessible. Let's go back to an emergency room where perhaps the electronic healthcare record. These are really critical things. And people need to be trained, providers, family members, first responders. So there's a lot of work in order to make this work. And other reasons why people struggle. People living with a challenge may find the legal forms difficult to navigate. Clinicians may be unsure of how to best incorporate PADs into clinical practice, or face competing pressures and lack of resources. Professionals who work in crisis settings may be unfamiliar with the tools and reluctant to give up their clinical authority or treatment decisions in a crisis, because there's often fear that they're burdensome or potential legal liability. Next slide. It's important to know, and Ira will talk more about this, that advanced directives actually are intended to enable self-determined treatment for people who lose decisional capacity and hopefully reduce the need for coercion, police transport, involuntary commitment, seclusion and restraint, etc. At the same time, PADs can be trumped by civil commitment law and overridden by clinicians, and Ira will tell us more about that. So I want to then introduce the next speaker, who is Alicia. I'm looking for my introductory, and I'm not finding it. So this is bad. And I may have to ask Alicia to introduce herself because I'm not finding it, and I don't want.
Sure, Harvey.
Here it is. I have it. He's the Vice President of States Advocacy at Mental Health America. Her work includes nurturing relationships with Mental Health America affiliates, generating leading-edge learning opportunities for the attendees of regional policy council meetings, and creating policy opportunities for affiliates. Her time as a policy advocate with the MHA of Southeastern Pennsylvania solidified her determination to center the voice of individuals with lived experience. She has a master's in social work from Temple University and is also a certified peer specialist. Here's Alicia.
Thank you so much, Harvey. I appreciate it. I know Lee's going to bump me to my slides. Great, thank you. So hello, folks. I'm a middle-aged white woman with blonde, wavy hair, and today I'm wearing a white shirt with colorful flowers. And I'm a person with lived experience I live with a mental health diagnosis. So I'm very pleased to be here today sharing the perspective of peers on psychiatric advanced directives. So I've been doing policy advocacy work for about 15 years, supporting individuals in recovery and the organizations that support them to be vocal about how policies and laws impact their lives. I firmly believe in nothing about us without us, and I'm privileged that my career has allowed me to work from that value. So I am a certified peer specialist, and I have facilitated the Certified Peer Specialist curriculum for about 4 years in Pennsylvania at one point in my career. And I also wrote the Pennsylvania Certified Peer Specialist Youth Add-on Training from the ground up. I don't think it's the one in use currently. This was several years ago. But I'm sharing because that means I have spent hours upon hours talking to people in mental health recovery who have received services and who have provided services about a wide variety of issues that impact their lives and their work. And during the Certified Peer Specialist training, when we were talking about the values of self-determination, self-directed care, and advocacy, we discussed the value of PAD at length. So I've talked to many folks in recovery about their experiences navigating mental health crisis services and their attitudes about psychiatric advanced directives and their experiences writing and executing them. It's from that bird's eye view that I'm sharing my perspective with you today. Next slide, please. So considering the history of mental health services, we must acknowledge that there is a long legacy of medical trauma and victimization of people experiencing mental health symptoms in crisis. We know about the misuse of mechanical restraints, punitive isolation, forced sterilization, and the weaponization of hospitalization of women and people of color. The ghost of this legacy is fear. We also know about the individual experiences where people report violations of personal autonomy. People who are given a medication they know doesn't work for them. People whose requests for privacy regarding who gets medical information was ignored. Or people who were forced to work with a doctor or a practitioner who has in the past belittled or disregarded their personal insight on how they experience symptoms. And when people are stripped of their personal autonomy, the result is a very appropriate mistrust and fear of the medical system. This is a community trauma. The experiences of some inform the fears of many. It is very human to fear the loss of personal autonomy. No one signs up for that. In some instances, this fear of autonomy being revoked results in people being reluctant to seek care. This pushes people further away from prevention and support and increases the likelihood of a crisis, emergency care, and restrictive treatment environments. So what are we going to do about it? As a community, we're going to come up with as many tools as possible to have a say in our care and give ourselves the voice for as much self-direction as possible. Self-advocacy tools like PAD offer people the opportunity to take back the medical autonomy that they deserve by having a clear plan. Next slide, please. So when talking to peers about a psychiatric advance directive, in my experience, people buy in. Buy-in is almost universal. Now, of course, there's a scale from optimists to pessimists. My fellow optimists believe their attitude is that it's better to have an advance directive and never need it. And then my pessimists believe it's better to have one and have it disregarded than to not have one at all. But most people, overwhelmingly, most people see the PAD as part of their arsenal of wellness tools and reflective of self-advocacy values. But more support and education is needed. People doubt the utility of the document. They have concerns about how an overburdened mental health system will perform. They doubt there is an understanding of why it's so important to communicate about and integrate their treatment directions and preferences into care. They worry that there's a lack of infrastructure needed to document their directions with medical providers, and that family or other decision makers won't remember or be able to locate the PAD. People don't know what kind of authority this advance directive has. They fear that doctors won't follow these directions out of disrespectful attitudes, or they'll dismiss their pad without even reviewing it. Peers aren't sure about the scope of the advance directive. When certified peers are supporting people to write plans, they want to make sure they're writing plans that can be followed and that they inform people that not all requests can be honored. Peers need more support in helping people to write advance directives that can be actualized. So now the flip side of all these concerns and skepticism is that vital foundation of recovery. Next slide, please. So as always, folks, here comes hope. Hope is the only thing stronger than fear. The only thing that can overcome that legacy of fear is change. And the only thing that drives change is hope in a better world. Peers over and over have shared that they are hopeful that doctors will learn to see a psychiatric advance directive as a practical tool, a tool that's not only for the person who has filled it out and who's experiencing crisis, but a document that's useful to doctors because it helps guide treatment, because attitudes and cultures of medicine change so that doctors understand that people are self-aware and introspective and intuitive, and that the self-direction that they have provided is often really accurate and the best medicine based on an individual's deep understanding of themselves. If someone knows a certain kind of medication will increase their distress, this is important information for their doctor. Their doctor will want to know that information, and peers recognize that they can be a teammate to their doctors, and their doctors can be a support for them. It makes sense to peers that mental health treatment is not a one-size-fits-all practice. And the hope is that with education, providers will understand that as well. Tangible
Alicia, you only have a minute, please.
Perfect, Harvey, thank you.
You're welcome.
Tangible plans that we as individuals have that express our desires and our needs are a tool for our doctors. And the goal is that in the future, doctors will value self-direction, self-advocacy, and most importantly, the understanding that recovery is possible. That'll end me, Harvey, so I can donate my time back to anyone who needs it. Thank you all so much, folks.
That was a wonderful presentation.
Thank you, Harvey.
I'm going to then introduce our panelists who are just experts in the field. We are very lucky to have them with us. I'm going to introduce them all right now en masse, and then I'm going to start asking them some questions. And the panel will be able to respond to them first, and then we have 15 minutes or more for you all to respond, and the questions will be packaged, and I'll be asking them. So Matthew Federici is the CEO of the Copeland Center for Wellness and Recovery, a peer-led nonprofit. He specializes in trainings to create wellness and community inclusion-oriented systems and to advance the peer support workforce through development and implementation of evidence-based peer-to-peer approaches and certified peer specialist programs. In addition to his role as CEO of the Copeland Center, Matthew develops and oversees the Doors to Wellbeing program and National Consumer Training and TA Center. He also has been involved in promoting PADS through local, state, and national consumer and provider conferences, including ours, as a matter of fact. Matthew brings over a decade of experience in promoting and implementing recovery and peer support programming by combining his knowledge of research, evidence-based practices, values, ethics, and his personal experience with recovery. Rachel Chambers is the co-founder of Painted Brain, a mental health tech nonprofit based in LA that provides peer-based services and practice training in technology and clinical mental health. She's also an independent consultant who provides capacity building support and grant writing for small nonprofits that serve communities of color. Her most recent accomplishments include organizing a national network for psychiatric advance directives, and she was recently featured in the LA Times for work in the mental health sphere. She's dedicated her personal and professional pursuits to designing and advocating for comprehensive health and human service programs that enhance the human condition of the most vulnerable populations. Kiran Sahota has nearly 30 years of experience in social services, notably contributing to community behavioral health through innovative programs, law enforcement training, and stakeholder engagement to address complex challenges and drive systemic change. After retiring as a senior behavioral health manager in 2020, she became president of Concepts Forward Consulting, focusing on digital transformation, strategic planning, and quality review projects, including the California statewide initiatives of CalAIM, Behavioral Health Services Act, and Electronic Psychiatric Advanced Directives. She holds a master's degree in clinical and community psychology. Dr. Neeraj Gandotra serves as the Chief Medical Officer for SAMHSA. He's been actively partnering with federal partners and national and regional organizations. He regularly meets with organizations to ensure parity for behavioral health organizations and attends organizational meetings at the Federation of State Mental Health Boards and the American Society of Addiction Medicine, and I'm sure many more. Previously, he served as the Chief Medical Officer for a large nationwide addiction treatment network, where he has developed national strategies specifically aimed at reducing risk and improving outcomes. He has also worked as a medical director for federally qualified health centers, where it was necessary to develop policies mindful of specific catchment area needs, and regularly initiated and developed psychiatric advanced directives as part of routine treatment planning and care of local patients. And finally, Ira Burnham is a lawyer and an expert on mental health law. For over 30 years, he was the legal director of the Bazelon Center for Mental Health Law. He helped draft 2 model laws on advanced directives and helped create the National Resource Center on Psychiatric Advanced Directives. Really encourage you to go to that site. It's really soup to nuts and really shows you the forms in every single state that has them. So I'm going to begin. I'm going to be asking questions of each of the panelists. They'll have about probably 3 minutes to answer them, and there'll be 2 minutes for the panel to respond, and we'll go through everybody in that fashion, and then we'll get to Q&A. So Matthew, my old friend, the role of peers, if you would talk about the role of peers in advancing psychiatric advanced directives and the work of bringing people to come together to complete paths as an empowerment tool. And I know you want to talk about the importance of funding for those peers.
Thanks, Harvey, and thanks to the whole committee. Given the time frame here, I'll just jump right into that. So when we take a look at any public health initiative, any important health topic initiative that needs to be driven out to the public, like education on the opportunities, the benefits of psychiatric advanced directives, these initiatives, the evidence is really strong that taking peers from those communities, this has been true of public education around HIV prevention, not just mental health, but we do know that there's substantial evidence because peers with the lived experience from those communities bring credibility, validity, and connection. But even more importantly, around psychiatric advanced directives, which I've been involved in for many years, watching people focus on developing the tool, getting laws passed, and then nothing happens. People aren't aware of them. They don't know how to implement them. And one of the biggest barriers to that is the optics of litigiousness that surround it. And it's really important that if you believe in promoting and empowering individuals to have choice and self-direction in their lives, the goal of this is at the center of that. And it's really important that we're not giving people advice about what to do. And the great thing about peer support, when people are well-trained in understanding the practice of peer support, is that we don't give advice, we give support. How do we do that? We do that by illustrating lived experience. One of our barriers is many of us that are doing peer support work and trained out there don't have our own advanced directives, our own psychiatric advanced directives. One of the other critical pieces is that pretty much all the major advancements in recovery, both substance use, addictions, and mental health, have come from peers working together in mutual groups, not isolated one-on-one providing peer support, but facilitating an environment of peer support in groups. So what we've been focusing on is working with each other as peers with lived experience in a supported evidence-based group process of exploring the topics that we need to explore for ourselves.
Matthew, you have 30 seconds.
All right. One of the big pieces of that is there's a lot of work that goes into evaluating and assessing our own supports in our lives. Who in our life is going to be a good advocate, that's going to make sure when we write this document that people see it and follow it. And that takes time and work and support. And so we've developed a model for peers to work together in a group setting to explore these topics. The goal isn't to write the document. The goal is to be prepared so it's easy to do. We understand it's important to do, and we're prepared to do it. But there's some time and support that needs to go in ahead of that. And that's going to be the most effective use of funding, is to support that approach. I'll stop there for time. Thanks, Harvey.
Thank you, Matthew. Any comments from the panel? You've only got 30 seconds. Now you have a little bit more. So Matthew, you have, oh, go ahead, Rachel.
Just chime in and say that I concur with Matthew's approach of the supported group model of helping individuals around their psychiatric advanced directives and preparing them. And then, as you'll hear in my next spot, is when that group support has finished, how we get you to actually implement it. So just shout out to the work that you're doing, Matthew, in the group supported work.
Thanks, Rachel.
Matthew, you have a training program established for training peers about PADS?
Yeah, there are certain core evidence-based values to how to set up a group environment, facilitate that group environment. And we're really focused in on how we storytell, how we create that environment through the important topics like knowing whether we want to take an agent-driven or instructional-driven approach, or both. Again, knowing where all the factors are that we have to consider in designating supporters and agents. So that's the approach, is facilitating through that.
Thank you, Matthew. Rachel, your organization, Painted Brain, has also been heavily involved in PAD education and peer supporting peers to complete their PADs. Can you say more about that?
Yes, I just want to start off by saying it's one of the best times in history and behavioral health history to be a peer professional. And I'll demonstrate that to you, how we're making moves in California with peer employment and advocacy. Over the past 36 months, Painted Brain and Campro, peer-run organizations in California, have incorporated the underserved voices of people experiencing mental health challenges in the development and implementation of PADS in California. We're a part of a 7-county initiative, which Karen will go a little bit more into it. And we worked to conduct in-person and hybrid listening sessions to gather the perspectives of consumers and community members around PADS. We interviewed peers, law enforcement, hospitals, and gathered feedback to make actionable recommendations on how we would create our PADS template. We supported in the development of our project that Karen will talk a little bit more about, of the PADS template, and we supported with the technology applications and designing the platform with the tech company, since our company definitely has a lot of background in technology and in training. And in conjunction with the 7 counties and the great peers across our great state in our counties, our 7 counties, we were able to work to develop a curriculum that has been implemented in 4 counties with over 59 participants, mostly peer supporters and health advocates, on a curriculum that will support an individual consumer to develop their PAD individually with PAD facilitators or with a peer supporter, utilizing a digital platform that we'll go a little bit more into that. But just so that you know, our peers in California really led the way in developing our approach to what we saw as a viable application and template to go on our technology platform. And just briefly, you can stop me because I'm trying to go fast, but some of the benefits, I just wanted to say, as someone that's been hospitalized and unfortunately falsely arrested, it's important that crisis responders know who I am and know my wishes. I also have a Black son that has autism, and it's important for him to have tools such as the PAD. So for me, this work and talking to all of our great residents of California about the importance of this tool, this is more than just a project for us at Painted Brain in California. It's now our mission to ensure that everyone gets a PAD to advocate for themselves and their voice in a time of crisis. We have a call to action to every state. Just real quick, we have a call to action for every state that's on this call to really mobilize your peers, work with lawyers, work with disability advocacy organizations to really push legislation and the use of pads. But that's more about our work. And Harvey, I don't know if you have any questions, but I tried to go fast.
I don't know if we have time for questions, but you know what? Kieran works with you, and maybe she can elaborate on some of this, because I really want to leave time for the Q&A, and we're a little behind. So, Kieran, you've worked closely with Painted Brain on innovative approaches. Particularly, I'm interested in hearing what you've done in the digital area. And whether that, for me, has some connection with EHR, electronic healthcare records. So, Kieran, would you do your thing?
Thank you, Harvey, and thank you, Rachel. And actually, I'm grateful because Rachel said a great portion of what I wanted to about our amazing peer contractors and the work that has been done. This project is peer-based, 100%. And without the voice of our peers, our family members, and our law enforcement and first responders, we wouldn't be where we are today. So when we look at pads and the innovation of pads, a digital pad has been in existence. With SAMHSA has a digital that you can have on your phone, or an advanced healthcare directive can be a PDF on your phone. But what we were lacking is that of access. And we really are looking at what happens to avoid that cyclical revolving door of inappropriate incarcerations, inappropriate hospitalizations, and unfortunately, sometimes worse. And we really were looking at how can an individual with consent give information to law enforcement so that law enforcement isn't trying to guess. They have the information, the preferences in the individual's own words. Substance use disorders, mental health conditions. This is how you can de-escalate me. Here's my preferred contact in the moment of a crisis. And what a better tool to be able to bring someone to baseline and never have to take them to the hospital, never have to incarcerate them, and instead contact their preferred contact who may be able to, in that moment, get them the appropriate services that are needed. So really taking that pad to that next level of, we have our peers that are going to help facilitate those pads, and that lived experience really does enhance that the completion of the pad. And so being able to then, only in what the individual wants based on consent, be able to provide that information. And so that's really where we look at that innovations we've never been able to access, and that's what we're looking at. Right now, it's a standalone website, but we have to train. And the second part of our project is looking for more counties in California to come on board, because we want to roll out the training law enforcement, training hospitals, training more peer facilitators, training information. This is why it's important. And to Rachel's point, this could not be a more exciting time in the peer community. In California, we are able to bill for peer services. This is a perfect opportunity to be able to bill. This is a perfect opportunity for peers to become involved and to give back to their own community of, I can sit with you because I've lived it. And the other aspect of it, and one last thing, Harvey, is we have an entire generation. I am the last generation that was born without technology. Every generation after me has been born with technology, and their expectation is, how can I do this digitally? It's easier for me to have it on my phone. How is law enforcement going to be able to access it? How are hospitals going to be able to access it? And we're trying to streamline that and make it so user and access friendly. So I know we're short on time, and
no, that is so important. Again, it doesn't matter that we've created really good tools so nobody can access them and are trained in them. You really nailed it.
Correct.
I'm going to go to the next speaker because I really want to make sure with this Q&A for the general group, and our speakers can join in that Q&A. Dr. Gandotra, you talk about, as a psychiatrist, how you support self-determination and the benefit of preparation, the issue of duty to care, and the ethical requirements of medical licensure, and the decision to declare somebody incompetent. Why don't we stop there with those questions?
Thank you, Harvey. And that is a lot to cover. I agree with everything that the previous speakers have said. And really what this comes down to is it's so much more than a contingency plan. Although it's sensible to think about the future and have that discussion with the patients, there are legitimate fears and understandable anxiety that's related to this sense of loss of control. But these are tools in particular that can serve a patient with a tangible and actionable plan. What I find is that not only do patients value the opportunity to make these decisions in advance, but it really does enhance the provider and patient relationship, that I've thought about it, they've thought about what could happen, what they would like to do, what treatment choices they would prefer. And also in the naming of a healthcare agent, I can never understate that it's someone that they trust to help make those decisions in that setting. My role as a psychiatrist, I routinely ask them whether or not they had one of these advanced directives. And most importantly, this is a quality standard. This is now part of our training. It is a quality standard for the Joint Commission. It is a quality standard for Medicare. This is something that is reimbursable as well. You know, sometimes patients are reluctant for a variety of reasons due to past experiences and interactions with, I would say, insensitive at best healthcare staff or law enforcement. But I'll quote our actual, our guide, which is the utilization of a psychiatric advance directive puts the power in the hands of the author, something that has often been elusive to the population that lives with mental illness. This is quoting Marcus Boyd, and it's from SAMHSA's guide on psychiatric advance directives. Now, obviously, the patient requires capacity in the preparation of the advance directives, and they're completed when the patient is not ill. This is where the setting is most important. Ideally, this setting should occur when the patient is in an outpatient setting or an environment where they trust those around them. And then there's key questions that have already been gone through, so I won't reiterate those. But the alternatives to hospitalization, the events that may trigger the psychiatric advance directive is key. And then one of the other places that is so often a focus is, do they want to be treated over their objection at that time? There may be times where they may be very ill or refuse treatment that they normally would find acceptable. Now, they can express their wishes about whether they want to be treated over their objection or not, and whether or not the healthcare agent that they designate might also have a say in that. So there's lots of nuances with this. And when it comes down to that question of is there a question related to capacity for that advance directive and making that informed consent, there's an activation point. That's sort of the key takeaway. And that activation point they can determine. And that is most important, that the person determines the activation point for this advance directive. It doesn't have to be capacity. Of course, many states, and I'm sure Ira's going to talk about this, talk about, you know, certain circumstances like judicial determination of competency or the activation of an involuntary commitment. But there are tailored, individualized points of activation that may allow for a more proactive use of these documents. And that's, I heard, avoiding hospitalization. This could be things as simple as what the patient identifies as triggers for them, warning signs for when they may feel that things are moving in a different direction than they would like. This could be spending excessive amounts of money as an activation point or failure to meet certain obligations. Now, I know that there's a lot more that we need to do in terms of training. Training for medical staff, training for healthcare professionals, training for first responders, training for not only psychiatrists, but the state authorities, health systems, all of that. You know, we have partnerships that we'd like to foster. And most importantly, communication among those who have developed these PADs and the tools. Professional development courses is something that we're heavily invested in as well. I'll sort of stop there because I know we have a lot of questions that'll be coming up from this.
Thank you, Doctor. Ira, go for it. You know, we're going to talk about the issues around rights and when are PADs trumped sort of by forced treatment and other things, and, you know, and medical practice and the National Resource Center and the difference that there are different PADs in different states. Will you want to take some of that on?
Sure. I'll just briefly make 3 points about the law, which is not the primary focus for today. The first is that advanced directives for mental health care should be treated the same as advanced directives for other health care. I mean, mental health care is part of healthcare, as we often say, and your right to appoint an agent to make decisions and to communicate your wishes to the person you appoint and to others should be the same for mental health care as for other care. So psychiatric advance directives aren't different than, or importantly, lesser than advance directives for other forms of healthcare or healthcare in general, and they should have the same legal force. And this principle is enshrined in the Americans with Disabilities Act, on which the Olmsted case was based, and it's also recognized by experts in the field and an important new model law called the Uniform Healthcare Decisions Act. So that's number one, kind of equality of treatment between mental health care and physical health care. Number two, as Harvey mentioned, an advance directive doesn't give you more rights than you would have if you were legally competent to make your own decisions. So you use an advance directive to communicate what should happen if you are deemed not able to make your own decisions. But it doesn't, but you have no more rights through an advance directive than you would if you were competent. And for that reason, an advance directive, for better or worse, it doesn't trump or override laws that authorize involuntary treatment in a hospital or on an outpatient basis. And as also Harvey mentioned, the care that you seek through your advance directive can be refused if the medical provider, the psychiatrist, the hospital, whoever, feels that the treatment you're asking for violates medical standards, because you're not entitled under the law or under an advance directive to treatment that the medical field feels is not appropriate. So that's number two. Number three, as Harvey mentioned, is that state laws about advance directives and psychiatric advance directives vary. How to create one, particularly what witnesses, how many witnesses there have to be. Some laws may have kind of rules of thumb that are followed. That is, whoever is reading your advance directive or whoever court that's considering it should assume the following unless you opt out of it. Sometimes there's a form that the law provides. So these are not big barriers, but they are details that it's useful to pay attention to. I think in general, if you have two witnesses sign your, two people witness your signature, and you're fairly clear about who the agent should be, what powers you're giving them, what you want, what you don't want. I mean, in those circumstances, pretty much everywhere, your pad will be legally valid. So
Thank
those
you.
are the 3 points.
I'm going to have to jump. So I'm asking Lee or the my Spark team to send me the questions. They're on my cell phone or in the chat box as we
Sure. I'm going to do it verbally for you,
That
Harvey,
would
because
be even
so many
better.
great
Even better.
questions. I know that there are a lot that are being asked, and appreciate so much folks giving their input and also asking questions. If we do not get to answer your question during today's session, we will be sure that your question gets answered by a member of the panel, and we'll be able to get back to you following up after today's session. So please, we appreciate everyone sending everything. But one for Harvey that we are looking at is, let's see. Sorry, I'm just trying to get back to find it. The one that we liked as much. How do your organizations make a pad portable and easy to access by first responders or others while someone is having a mental health crisis? Have anyone considered making this a part of the international patient summary?
Well, I don't know. I think you're right. I won't answer the second question because I don't know the answer. And in the first one as well, no, we don't. We have a form. It's being revised by us and others. We do training on it, but I don't think it by any means it's been shared with. There's no routine where it's shared with law enforcement or first responders. So we have a ways to go there. I mean, there's a number of things that we've talked about here that we have to fight harder for in New York. Next question. For anybody?
We have another one that's asking about training for families. I wonder if Rachel would like to speak to that one as a family member.
Yes, I think that as Matthew and myself, I'm sure there's a number of organizations that are starting trainings around preparing for your psychiatric advanced directives. Our training that California is pulling out is heavily informed by family members, and Karen can correct me if I'm wrong, but it will be a public document at some point. So yeah, do you want to speak to that real quick, Karen? Yeah.
Yes, as we look at creating this innovative project, the idea is sustainability and replicability. And so it will, everything that we create in our platform, it's going to have the trainings, the information, the digital form. And so all of that will be, and actually we're looking at our threshold languages as well. So California has 17 threshold languages. In the 7 counties we're working with right now, there are 7 languages we're working with. So we really are trying to make it user-friendly for families. And again, and then there's a completely different training for law enforcement and hospitals because they're the ones that are looking at that access component of it. So I think that helps.
Yeah, and just real quick, I know we don't, but there was like multiple statements in the chat about concerns about law enforcement. So I think that's one of the big things pinpoint that we're trying to work on in California, and access with, getting other people access to that document and the misconceptions. So we need to work through that. And I think that's the importance of peers working across the board with law enforcement and crisis providers so that we can work on legislation and training. That will be the key. If you don't leave this training, like knowing that, please, that's your call to action. Let's start getting those conversations going.
Let's keep that going. Maybe we can, as part of this team, we can be available and share how we can be a resource and an encourager for doing more work with law enforcement and first responders. Here's a comment. There's a wonderful tool. We often interact with people pretty far down the road into their struggles. How can we help people to complete this document when they lack capacity to provide consent? You want to take a crack at that, Matthew? Is that something you're comfortable with?
Find the unmute. Harvey, could you just repeat the question again? Because I was actually.
Yeah. How can we, essentially, the quick version is, how can we help people to complete the document when they lack capacity to provide consent?
I think that there's no time that we can't listen and engage. And I think actually it was one of the colleagues there at Painted Brain when we were working together on this said so astutely, which is just because I make some bad decisions doesn't mean I can't make any decision. With that said, someone being classified as not having competency by medical professionals is not a time when you're going to get that written into a validated advanced directive, in my understanding. But I don't think there's any time that you should stop honoring and listening. And I don't think there's any time we should just discount that anything a person is communicating to you is not valid. I will share that during a very emotional crisis that had my loved ones very concerned about me, I knew I didn't have a choice in what psychiatric hospital I was going to, but my family still involved me in the decision and was privileged enough to give me choices and options in what psychiatric hospital I was going to. In the end, I don't think any of them were in my best interest. However, just being involved and loved enough to be asked of these places, which one would you be more comfortable in? And I was not making great choices at that time in my life, but being involved in that level went a long way to how things went after that. And so that's why I really believe it's always important to be listening to folks. We need to make our best efforts. And I'll cite again, the federal Patient Self-Determination Act is a huge component about what this is about, regardless of what your state's opinion is on it.
Thank you, Matthew. That's such a great, unfortunately, we have to end apparently, right, Julie?
We are at that time, unfortunately. And so I'll just thank all of our attendees for joining us and for your thoughtful questions. And thank you again to our amazing presenters and panelists and to the Spark team for supporting this webinar. We'd love to hear your thoughts on this event. If you have a moment and you can fill out this brief survey form, I'll also just drop it in the chat right now. Oops, that did not copy paste. We would love to hear your thoughts and so we can continue to make events that are meaningful for you all. And I don't know if someone can drop that in the chat for me. That would be amazing. I also wanted to just take a brief moment of your time to invite you to an event coming up, and that is the Walk for Recovery that's being hosted in DC in September, on September 5th. And so if you're in the DC area or if you want to travel to the event, even better. But we're hosting that from 2 to 5. I think it's going to be a lot of fun. So if you want to get more information, you can register. I did find that link with the QR code on this slide or with the link in the chat. So we'd love to see you there. And thank you all so much. Hope you enjoy the rest of your Friday, and thank you again.
And before we close out, can we just make sure that everyone has access to that SurveyMonkey link? It's being added to the chat as we continually see others thanking us for this wonderful webinar. Thank you so much. Special thanks to you, Julie, and to the team at C4 and to the panelists. Thank you.
Just so folks know, the link will actually open up following the closing of this meeting. So just take a look at your browser. That will open up for us. And if you have any issues receiving it, please, I'm going to put our Spark email in the in the chat. So you can also feel free to send any questions and request TA. So spark@c4innovates.com is the place to go. And we thank you so much for your attendance today. Thank you so much.
Self-determination rules, folks.
Thank you, everyone.
Love that.
Again.